I'm Dr. Robert Odell. I'm going to do a demonstration on my patient of the injection for diabetic neuropathy. She actually has idiopathic neuropathy, and her neuropathy is through the entire foot up to about here, about right. Because of that, we're going to do all 5 nerves. We're going to do the sural, the deep perineal, superficial perineal, posterior tibial, and the saphenous nerve. And we're going to do them on both sides. Now we're going to start on this side. We're injecting 1/4% Marcaine, which is without epinephrine, of course, and we actually go a couple inches proximal to the malleolar line. One of the reasons is so we can get away with a much smaller, much lower volume. We use about 8, 9, 10 cc's in each ankle, and we actually allow patients to drive home. We've never had a problem. The electrical device, the electroanalgesia machine, will actually increase the numbness, the feeling of numbness, but with this low dose, it's not a problem at all. By comparison, when the surgeon, my podiatry colleagues, or when I do an ankle block for surgery, we might use 20, 25 cc's of 0.5% Marcaine. So a lot less molecules, cutting down the risk substantially. Now I'm going to start with the sural nerve on the left, and this is just anterior to the Achilles tendon. Remember, and it's very superficial, and the sural nerve, we inject 1 cc just anterior to the Achilles tendon, right here. In this case, we don't have to worry about injecting close to the Achilles tendon because we're not using steroids, so there's no risk at all because we're using local anesthetic only. The next nerve we're going to inject is going to be the deep perineal nerve. And Tina, if you can bring your leg up, this is the extensor hallucis longus tendon right here, and then lateral to that is the extensor communis. So right between that, right about here, I'm going to inject. I don't want to hit the tibia, so I'm going a little bit lateral, and that's where the deep perineal nerve lives. I pull back, and I'm injecting 2 cc's. I'm going to do the superficial perineal nerve, and I'm not going to pull the needle out because I don't want to hurt the patient. This is sub-Q, and I'm doing 1 cc medial, and then I'm going to do 1 cc lateral. And if you want to use a few more cc's in somebody with a little bit bigger ankle like hers is, you can also do that. The superficial perineal nerve kind of comes down with a few strands in different areas, and 1 cc, 1 inch on each side, should generally get all the branches. So sural, deep perineal, and superficial perineal. Once again, we're doing all 5 nerves on her because she has a true stocking or sock neuropathy. Now the next nerve is going to be the posterior tibial, and we want to get a different angle here. I'm going to be putting my finger right on her malleolus, and 1 finger breadth posterior to that, and then I'm going up again a little bit north, and there's a groove between the Achilles tendon and the posterior and the other muscles. And if you go down about halfway, you go ahead and inject 2 cc's, maybe 2.5 cc's if you'd like. You should catch the nerve there. Now the posterior tibial nerve is very large, so if the patient exhibits a paresthesia, you got to pull that needle back because you do not want to inject interneurally. We never want to do this with the patient asleep. Again, in my experience, the only nerve that can be injured would be the posterior tibial. The other ones generally just fall away from the needle. I now move the needle medially. This is the saphenous nerve, and again, I put another 1.25 cc's for a total of 9 cc's in her left ankle. And that basically is how it's done. That was the saphenous nerve, which is the only nerve that's not from the sciatic nerve. It's from the femoral nerve anterior. Now I'm going to go ahead and repeat this on the other leg. And as I said again, because of the low dose and the low volume, we are comfortable with the patient's driving. This again is the malleolus, 1 finger breadth behind it. Okay, we are putting the needle in right here. Now she has quite a bit of numbness, so we're not using the spray and stretch solution that we do use with a lot of patients. Many patients who do have this is the saphenous, who do have this procedure will often feel more pain, especially after they've had numbness. And actually, even though this procedure is hurting them more, I tell them that that's better because, in fact, their nerves are starting to wake up. Okay, here's the flexor extensor hallucis longus, and just a little bit lateral. In fact, what I think I'll do is I'm sorry, Tina. Thank you. Thanks a lot. I'm gonna inject here. I'm gonna inject down about. This is an 1.5" 25 gauge needle, 27 gauge needle. I'm going to inject about halfway, 3/4 of the way down. Now I'm going lateral for the superficial perineal. Inject 1.5 cc's, and I'll inject the rest of it in a medial direction. Again, it's about 1.5 inches, so you're getting about a 3-inch spread of the to catch the superficial perineal. Now. I have 1 cc left here, and with 1 cc I'm going to use that for the sural nerve. You may recall we did the first one on the other side. Again, here's her Achilles tendon. You can feel that groove right there, and this is you don't need to do a field block here. It's a very superficial nerve. You just go in just like that, and that's all you need to do, and we're basically finished. Now, one thing we do is myself or my technician Yolanda will put these little bandages on each spot. The reason for that is because, first of all, it's for sterility, it helps. But when we put these electrodes on, as she'll show you how to do in a minute, we do not want to have any blood get on the electrodes because we reuse these sponges, and of course we can't do that if for a variety of reasons if there's blood on them. We do treat them with microwave them once a week, and treat them with a special antiseptic solution daily in between treatments. But this is just another precaution that we take to maximize the sterility. Now Yolanda's going to show you how to put the Yolanda, can you put the electrodes on? I'll talk while she's putting those on. Oops. Once Yolanda's cleaned the betadine off, we'll go ahead and put the electrodes on. We try to do this within 15 minutes of the treatment. Usually it's not a problem when we're doing the peripheral blocks. Sometimes when we're doing neuraxial blocks, especially at the surgery center, patients had some anesthesia. Sometimes time is allowed to go by, but we want to try to get the machine on before the majority of the Marcaine has had time to fixate. The reason we use Marcaine is because it takes longer to get in and fixate to the tissues. So the vasopulse here is turned on, and these come out of a solution of alcohol and water, which we'll tell you about. Tea tree oil.
Not alcohol.
I'm the doctor, don't.
Just giving you the right info.
This is a mixture of tea tree oil and water. Keep it sterile. And you ready?
Yeah.
You want to put them on? You're the expert. So you put the green ones. Let me give them to you. The green electrodes, positive electrodes, go proximally, and the other electrodes, the white electrodes, go distally. The orientation of the red and green does not matter because they're in a perpendicular situation. Montage, it's called. Montage means the shape of the electrodes and the position they are on the body. I'm going to go ahead and repeat that on the left ankle, and then we'll turn the machine on. Smell? Okay.
No.
All righty.
Ready? What do you want me to do? You want me to turn it up?
We can do specific training, of course, for details. I don't have to get that on this.